Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. Today, again, we have Dr. Greg Sirounian, who is Clinical Assistant Professor at Winthrop University Hospital, and we'll be discussing about knee surgeries. Dr. Sirounian, welcome.
Thank you.
A couple of months ago, we spoke about the hip replacement and hip injuries. Let's talk about the knee injuries and knee replacement right now. How often do you see a patient that needs bilateral knee replacement? Let's start from that.
Bilateral knee replacement, or meaning having both knees replaced. We're doing the replacement for arthritis of the knee. And many patients, if they've got severe arthritis in one knee that's bad enough to need a knee replacement, often they'll have the other knee that's equally as bad.
Right.
Now, the question of whether or not we're doing or taking care of both knees at the same time is really depends on the patient, probably their activity level, their level of motivation, and their overall physical health. Right. Absolutely.
And mental health too, ready to be both knees. Right.
Very important.
Right. So before knee replacement comes in the picture, most of the time there are some injections, some medications come in the picture.
Right.
How often patients can get injections, like cortisone injections, let's say, for their knee?
There are, I think, different opinions regarding how many injections a person can have, say, within a year or a lifetime. In reality, there probably isn't a limit per se, but my own practice, I try to, I want them to be effective enough that we can space them out, say 3 or 4 months or more apart. So if somebody's coming in every 2 weeks telling me they need a new injection, I think, well, it's probably not working at that point.
Right. At that time, probably they need knee replacement.
Right. Right.
So now recently, obviously in the past already was total knee replacement. Now there's a partial knee replacement. Who is candidate for partial knee replacement?
So the partial knee replacement is essentially it's a half of a total knee replacement. So a total knee replacement replaces both sides of the knee with metal and plastic. And imagine a partial knee replacement, you just take a saw and you cut that, well, it's not a saw, but you cut it in half. So it's a smaller implant, and that implant is designed to replace just one compartment in the knee or one part of the knee that's damaged.
In terms of recovery, is it the same or is really much shorter time? That's why people have usually partial knee replacement.
The partial knee replacement is appealing because in general, and it's not true for everybody, but in general the pain and sort of the weakness and the things that come with a total knee replacement are going to be a little bit less than in a partial knee because simply put, we're not cutting as much.
Right. And they're ambulated much quicker probably, and the recovery might be much quicker. Let's, from the knee replacement, let's go some cartilage injury in the knees that is much more common. Obviously, we see in young people too, not only elderly. What is the treatment? How do you handle the cartilage tear when patients come to you? So
cartilage tears or meniscus tears, some people may be familiar with that term. Meniscus is basically cartilage in the knee, and it's a very common structure to tear, especially as we get older, and especially in those of us who are very active with a lot of sports or heavy labor type activities might be more inclined to getting a tear. Many tears can be managed non-operatively because we generally want to treat the symptoms. We're not going to make the tear go away. Okay, cartilage in general doesn't heal itself well, especially as we get older. So in general, things like anti-inflammatory medications can be useful, physical therapy to help strengthen the muscles around the knee, and sometimes once in a while we might do an injection. And if people are feeling well symptomatically, a lot of times that's all we'll do.
Right. And sometimes they go to physical therapy.
Right.
After injection or after treatment, that physical therapy might be helping them a lot.
Right.
Now, there are different types of injections that they get weekly. They come to patients and say, well, I went to the doctor, and he is recommending now weekly injections 5 times I'm going to go. Can you just talk about it?
So what you're talking about, the big term for that is supplementation. Right. Basically, it's a gel. It's a syringe with a clear, thick fluid in it, and it's really designed to mimic our normal, healthy joint fluid, the fluid in our joints. To help perhaps cushion or nourish the cartilage. Lubricate the cartilage, exactly. It's not, I always tell patients, it's not a substitute for cartilage. It doesn't regrow our cartilage, but it can offer pain relief.
Let's talk about arthroscopic surgery now.
Right.
So how effective it is for cartilage tear or meniscus tear?
So for meniscus tears, it can be very effective if somebody has a relatively healthy knee, or say they had a knee that generally felt pretty good up until they tore their meniscus or cartilage, and say they're getting symptoms, what we call mechanical symptoms, like a locking sensation, like the knee is perhaps getting stuck, or like it's buckling or giving out all the time, popping. Sometimes, a lot of times, those patients can get good relief or good benefit from an arthroscopic surgery. I think somebody who's got more arthritis or more degenerative, worn-out knee is less likely to get benefit from an arthroscopic surgery.
After the, let's say, arthroscopic surgery, what is the time frame that they can go back to work or they can do their routine activities?
In general, most people can get back to their normal activities within a couple of weeks, anywhere from 2 to 6 weeks, depending on what they do. I tell my patients, my more athletic patients or the heavier labor type folks, it may take them longer than 6 weeks sometimes if they're expected to, say, lift 100-pound boxes and things like that. That's
so a labor worker, there might be a little longer time to go back to work.
Right.
Is there any other type of treatment besides the arthroscopic surgery for the knee cartilage, or that's all we do and attend on physical therapy?
Most of the time, arthroscopic surgery for cartilage tears, that's probably about the only predictable treatment or predictable surgery that we have. There are some procedures where they talk about replacing or repairing cartilage, and I think a lot of that is still being investigated. We're not quite sure where it fits in right now.
One thing I'm going to come in, that the reason I asked that question is that stem cell injections or stem cell related repair of the cartilage that I was talking about. Is there anyone in the practice that doing that right now?
In our practice, no, and simply for a couple of reasons. One is the research on it is still limited. The stem cells have some functions in orthopedics, but in terms of cartilage repair, it's a very narrow group of patients that might benefit from that. And the other reason is costly, and most insurances won't pay for it, and patients are paying out of pocket for it, and it's hard for me to recommend something if
it's not covered by insurance, and it's very expensive.
Very expensive, and it may not work.
Yes.
So
probably in the future, hopefully in the near future, they might come and regrow the cartilage for us.
Perhaps by the time I hurt my knee.
Dr. Sirounian, thank you again
for
coming to our program. It was enlightening. Now it's time for this week's article. It is Magnesium Supplementation and Arterial Stiffness. Magnesium, an important element for many functions in the body, and it is linked to osteoporosis, migraine headache, constipation, PMS, chronic fatigue, and heart attacks. Magnesium is also an important element for blood pressure regulation. Blood pressure is a major determinant of arterial stiffness and is predictor of ischemic heart disease and cardiovascular disease mortality. Studies have found inverse association between dietary magnesium intake and cardiovascular disease risk. Each 200 milligram increment in dietary magnesium intake was associated with 22% lower risk of ischemic heart disease. Researchers from Netherlands evaluated the effects of long-term magnesium supplementation on arterial stiffness. 52 overweight individuals were assigned to receive either 350 milligram of magnesium or placebo for 24 weeks, and arterial stiffness was evaluated. The end result of this study was daily magnesium intake of 350 milligram for 24 weeks reduced arterial stiffness. This study suggests that magnesium intake is beneficial for cardiovascular health. Although magnesium supplements are available, it is preferable that you get magnesium naturally from your diet to decrease arterial stiffness and improve your cardiovascular health. Many foods contain magnesium. Green leafy vegetables like spinach and kale are loaded with magnesium. Besides green leafy vegetables, pumpkin seeds, nuts, yogurt, fish, avocado, banana, figs, and dark chocolate have magnesium. So include these foods in your diet. Good health is precious and priceless. Keep informed. For up-to-date medical information, visit AAHPO's website, AAHPO.org. I'm Dr. Ohan Karatoprak. Until next program, so long.